calcium and vitamin D, how does it usually present in children?
So vitamin D is naturally available in sunlight. Unfortunately, they are not exposed enough. Makar Sankranti especially.
Yeah.
They distribute yellow sesame seeds.
Yeah.
It's because the sun shifts its cycle from Dakshinayan to Uttarayan during that time.
What is scoliosis?
Scoliosis basically means that there is a deformity in the spine, which is usually an S-shaped deformity.
Okay.
In my clinical practice, I myself have a WhatsApp group, which consists of all the club feet parents. Basically, it's a support group wherein the parents who have already dealt with this particular problem, they can support the other parents.
Now that you're saying that you're making bones grow longer, parents will be like, okay, what can we do to optimize the height of our child?
You'll not believe I've had so many requests like that.
Yeah.
My suggestion is love yourself. If you're short, big deal.
So, are there any recent advances in pediatric orthopedic surgery that you're excited about?
We have done a few surgeries with these 3D printed models, and it makes my job so much easier.
How would the parents know if the child is immunocompromised?
If a child is having more than 2 episodes of fever in a month, these are the children who probably end up with.
Hi, I'm Dr. Lakshmi, a family physician, and today I have with me Dr. Manjush Halbhavi, who is a pediatric orthopedic surgeon. So, what is a pediatric orthopedic surgeon? Right? So, I have so many patients coming to me telling me that their child has heel pain, leg pain, and if this is normal, like what is normal? So, we are going to find that out today with Dr. Manjush.
Hi, Dr. Lakshmi. Thank you for having me on the show.
Yes. Okay. So, what is it that you wish parents knew about, like pediatric bone health? What is it like? How is it different from adult bone health?
See, one common myth is, children are not small adults.
Yeah.
Okay. So what happens is the bone structure as well as the bone morphology in children is totally different from adults. Because of this one particular thing called physis.
Okay.
Physis is basically the growing end of the bone. That is what helps in the child, growing from a small baby to a complete full-fledged adult.
Okay.
You might be surprised to know, the trunk and the legs, when we look at it from the growth perspective. So the trunk tends to grow close to around 3 times the size, whereas the bones tend to grow close to around 5 times the size.
Okay.
So a lot of these problems what we see, especially in the again, we tend to differentiate these things into truncal deformities as well as the limb deformities.
Okay.
So again, in the limb deformities, depending on which plane, in all the 3 dimensions, deformities can occur. All of these things typically happen because of either a problem in the bone morphology itself, that is due to endocrinal anomalies, or because of genetic defects. The bone structure itself will be different in some children. And the second and really very commonly seen problem with pediatric age group is calcium as well as vitamin D deficiency.
Okay. So this calcium and vitamin D is actually a very common problem, right?
Yes.
So parents would like to know. So genetic and endocrine, you can't change it because it's genetic, it's endocrine.
Yes.
So that they either have to give medicines, they have to go
Correct.
to a
They'll
specialist.
require treatment is what you're saying. Correct.
But calcium and vitamin D, how does it usually present in children, and what can parents look out for?
Correct. So, see, Indian diet typically contains good amount of calcium.
Okay.
See, we are a population who eat good amount of ragi, we drink good amount of milk. At least the non-vegetarian population, they have sufficient, animal protein as well as calcium intake. So, overall, the calcium intake in the Indian population is reasonably okay.
Okay.
The major problem, especially in urban folk, is vitamin D.
Okay.
So if you remember our childhood, all of us, I think at least in my childhood, I would always be on my shorts and I would be in the ground full time.
Yeah.
So unfortunately today, due to lack of space, due to pollution, due to, mobiles.
Yeah, yes, definitely.
So most of these children, they tend to, have this indoor sort of lifestyle.
Okay.
Which predisposes them to have this vitamin D deficiency.
Okay.
Yeah. So vitamin D is naturally available in sunlight. Unfortunately, they are not exposed enough, in the sunlight for them
Yeah.
to get that naturally available vitamin D source.
So, at which age is it important for them to get the vitamin D?
Straight from the birth,
Mhm.
I don't know if you remember, an age-old Indian practice
Mhm.
is basically all our ajis, our
Yeah, yeah.
grandmothers, they would make us, stand in the sun,
Yeah, yeah.
and they would
They'll
give us
give
this oil
oil
massage.
massage and
Yes,
put you in the sun. Yes,
correct.
yes.
So this is something which most of my kids, they come and they say, "Arey sir, we do oil massage regularly,
Uh-huh.
but still the child has some calcium or vitamin D deficiency. How does it work that way?"
Yeah.
Then ask the parents, where do you do the oil massage? Sir, inside our house.
Yeah.
So the whole concept of oil massage is that the child is getting sufficient sunlight.
Yeah.
Child is getting exposed to the sunlight.
Mhm.
Why do we do the oil massage in the first place? We do the oil massage so that the skin doesn't get burnt because of the sun rays.
Mhm.
We didn't have sunscreens back then. You
Yeah.
remember? So
Yeah.
because of that, the oil massage itself is not the benefit.
Mhm.
It's not the oil massage that is beneficial.
Yeah.
It is the sunlight exposure in which the oil massage is done.
Yes.
Understood?
Yes.
So that is where probably if we don't know the reason why we do what we do,
Mhm.
things tend to go a little wrong.
Yeah, because we kind of like leave the practice and we're like, okay, like why would we do this like this? Why would we go out in the sun, like like in the
Exactly.
morning
Exactly.
rays and all of that?
And another thing, probably, since we are on this topic, during Sankranti, Makar Sankranti especially,
Yeah.
they distribute yellow, sesame seeds.
Yeah.
The reason why that is done is because, the sun shifts its cycle from Dakshinayan to Uttarayan during that time.
Yeah.
And since then, the sun rays become progressively more
Like sharper?
sharper. Exactly.
Okay. Mm-hmm.
So because of that, the naturally available vitamin D starts getting absorbed in the sun,
Okay.
and sesame seeds is an excellent source of calcium.
Okay. So exactly. So you need vitamin D to absorb calcium, right? So everything which was done before was for some health,
Reason.
yeah, some health purpose or the other, but we just lost it because we weren't sure and we weren't told about it too.
Exactly. So every
Yeah.
time you ask your parents about this particular thing, the
Mhm.
one thing most of them say is, this is a ritual. You're supposed to do it.
Mm-hmm.
When we understand what we do and how we do and why we do what we do,
Yeah. Because
So-
most of us are quite rebellious by nature. You'll be like, okay, you're telling me to do this, I will not
I'll
do
not
this.
do it. Exactly.
Yeah, yeah.
Especially
But
children.
yeah, yes, yes, exactly. But yeah. Okay. So that being said, so vitamin D and calcium, those are the basis for most of preventable issues.
Correct.
Things that you can't prevent. What are they? And is it like, is surgery the only option for those kind of problems? And how would parents know when to come to you? Because in Bangalore, from what I've seen, I don't think many people know about pediatric orthopedicians. They know, okay, if we have anything related to the bone health or bone pain or anything, we go to ortho, right? But I don't think many people know that there's an option of pediatric ortho. Yeah? Okay, so.
So see, when the parents are supposed to get the children, typically off late the trend has been shifting towards nuclear families.
Okay.
So most parents will have one kid,
Mm-hmm.
and it's a closed family, it's a close knit circle. It's usually the grandmothers who pick up this particular problem.
Okay.
The child is not walking as quickly as it's supposed to do.
Mm-hmm.
Sometimes the child is walking funny when
Okay.
compared to the peers.
Mm-hmm.
The reason why it's usually the grandmothers who
Okay.
pick up this thing is because grandmothers have seen more kids
Okay.
in their lifetime.
Yes.
They know what is normal. They know what is probably not normal.
So, for parents who are watching this, if they want to know what is normal and what would border on abnormal when they have to come to see you.
See, a simple suggestion is if you have a doubt, please get them.
Okay. Okay. Yeah.
So because alarm bells start ringing quite soon for some parents, and for some parents they tend to, wait.
Uh-huh.
Okay. If you have a doubt in mind,
Mm-hmm.
it's always better to at least consult the pediatrician, if not the pediatric
Yeah,
orthopedic
yeah.
surgeon, because we are a rare folk, we
Yeah.
are probably not available everywhere.
Of course.
And even, in a metropolis like Bangalore, there are, hand few of pediatric orthopedic surgeons.
Okay.
That being said, if you have a doubt in mind, at least consult the pediatric doctor.
Okay.
So the
Okay.
pediatricians, a sincere request to all pediatricians probably would be to, if at all you don't know what exactly is happening, it is better that you, you know, take a referral of a pediatric orthopedic surgeon, so that it's easier for, we don't miss out on these things, the minor things which sometimes tend to get neglected.
Yeah.
I think it is better that a pediatric orthopedic evaluation happens if there is any such sort of doubt in mind.
Of course.
Yeah.
Yeah, because like children, they do have like lots of aches and pain. So what is growing pain and when should they come to you is a big gap, right?
Yeah. I mean, most of the children with growing pains, invariably, when we do their blood investigations, they'll have one or the other deficiencies like this, the calcium as well as the vitamin D. Um, that being said, there are certain red flag signs probably which we need to focus on. Typically, one thing is we call this as developmental milestones. So, what exactly is a developmental milestone? A child is supposed to, you know, do certain motor activity in certain age time. It's not exactly a particular date. Say, for example, we talk about, when the child is born, he or she will not be able to hold the neck by themselves. So, what we do is we support the neck, correct? So, this support typically the child is able to do by themselves by approximately 3 months, is what we say. But it is not exactly a one day thing.
So
At two,
how
2.5 months.
important is it? Because like the developmental milestones, because see, we don't want the patients to get too scared. We want them to be confident with the information that they have, right? So like say 3 months, and say it takes like a few extra days.
So
and
typically that's what I'm saying. It's never a single day.
Okay.
It's always a range.
Okay.
Okay.
So that's important. That it's
Yes.
always a range.
It's always a
So
range.
if it doesn't happen within a longer period of time, then after that they can bring
Correct.
the child
So
to you.
typically, when since we were discussing about neck holding,
Yes.
neck holding usually, although we say by 3 months it should happen, we can wait up to around 5 months.
Okay.
Okay. If the child is still not able to hold the neck itself at even beyond 5 months, say at 6 months of age also, that is when I think it is important for the pediatrician to see the kid first,
Okay.
then refer them to a pediatric neurologist and
Okay.
a pediatric orthopedic surgeon.
Okay. Okay.
Okay. So typically, what happens in such children is basically sometimes, during childbirth, there will be some sort of reduction in the blood flow to the brain.
Okay.
And that sometimes predisposes these kids to have this sort of motor problems at a later point in time. Okay.
Okay.
So here I would like to talk about something called as cerebral palsy. Right. Cerebral palsy is basically, again, injury to the brain which happens either in the just before delivery, during delivery, or just after delivery.
Okay.
Right. In this phase, if there is any sort of hamper to the blood supply to the brain, kids tend to have one or the other motor deficits.
Okay.
So here, typically, again, like I said, at 6 months, if the child is not able to do certain things, that is when the alarm bells have to start ringing, and that is when we start, evaluating the kid. Typically, how it works out is basically the management as such, it is mainly with the pediatric neurologist, the physiotherapist, the orthotist, and us as pediatric orthopedic surgeons. So, team-based approach is what is going to help the child, to come out with flying colors.
Yeah. Yeah. So, of course, so parents would be like really scared, right? Like when they hear this, they'll be like, oh my God, like, like is the kid not going to be able to do anything? But if you have like timely intervention, everything can be helped and sorted, is what you're coming to say?
Yeah. When I say, things can be sorted, it's not like we have a 100% cure wherein, there is, the child will be able to play sports like the other kids. No. What we can do is we can, make sure that the child gets to the best of his or her abilities.
Yeah. Yeah.
Understood?
Yeah.
Like her ability probably because of that injury to the brain might not be 100%. It might be just 80%. But without intervention, that 80% will probably stop at 40 or 50.
Okay.
With interventions, we'll be able to make sure that the child grows to the fullest of his or her potential.
Okay. Okay.
Understood?
Yeah.
So although we talk about, a lot of these parents, they get fed up over a period of time because this is something which has to happen till the child is at least, 14, 15 or up to 18 years of age. And even then some kids will require support. at one point in time, the parents, they tend to become very frustrated.
Yeah.
Arey sir, how many more days do we have to do this particular thing?
Yeah.
So that is where patience is advised.
Yeah.
I agree. It's so
Definitely.
easy for us to talk about it in a podcast show like this, but
Yeah.
for the parents to deal with this on a daily basis, it's really
Yeah.
difficult. It's very heartbreaking to see these kids as well as the parents.
Yeah, that is true.
Unfortunately, there is no way around it. The only way is to
Because if it's already happened, then after that you have to like manage it. Management is the only option.
correct. One good
It-
news about this particular brain injury is it's not a progressive problem.
Okay.
Cerebral palsy is not progressive. Only thing is, because of the brain injury, whatever happens is the muscles don't grow according to the growth of the bones.
Okay.
And because of this, they are more prone for spasticity and contractures and this sort of thing.
Okay.
So, that is where physiotherapy helps in the initial few years. And at one point in time, if it is not getting better with physiotherapy, that is where we as orthopedic surgeons, we tend to do, interventions, surgical interventions.
Uh-huh.
We call them as gait improvement surgeries,
Okay.
wherein we do, releases and transfers,
Yeah.
so that, the child's gait pattern improves.
Okay. And it actually improves the quality of life as well, right?
100%.
Yeah.
So
and that's so
although a
important.
child who is not able to walk will not be able to walk after the surgery,
Uh-huh.
a child who is walking a little, funny probably will have better gait when compared to prior to the surgery. And that
Okay.
is where surgeries definitely help in children who are, who really require them.
Yeah.
In fact, before surgery, we also have other therapies like botulinum injections and stretch casts, stretch plasters, and these things are done in the initial phase.
Okay.
But once a contracture sets in, unfortunately, there is no other go but to go in for surgery, and they do become better.
Okay. Okay. That's good. So these are the most common congenital problems that you see?
No, I mean, there are so many other congenital problems. Once we talk about congenital problems, the most common congenital issues what we see in pediatric orthopedic practice is clubfoot.
Okay.
So, clubfoot is basically, there'll be a combination of deformities which makes the foot to turn inwards as well as downwards.
Okay. So how can a parent recognize this when they see it? Like.
So most of the club feet what we see, they'll be picked up in the antenatal anomaly scan.
Okay.
Okay.
So some patients have come saying that they are, our, obstetrician, like after getting the anomaly scan done, has asked us to go and see the pediatric orthopedic surgeon. Is this normal? Nobody that I know has ever had to go here. Why do I have to go? Is my baby going to be okay? I understand that fear, and now you will explain what happens.
Yeah. So basically, the reason why prenatal counseling becomes important is because as parents, there'll be so many questions, so many doubts, whether my child will be okay, whether, my child will be able to walk, whether my child will be able to do the activities, whether will he be picked on in the school. So many questions.
Yeah, of course.
And what do we have to do about this? So many, not just the questions, it's so many myths also,
Yes, yes.
So when there is a problem like this, the child will never be able to walk. No, all this is nonsense, I'd like to give you a very nice example, okay? Have you heard of Steven Gerrard?
Yeah.
So he is an English footballer. He retired as the captain of English football team as well as captain of Liverpool Football Club, which is quite a famous, it's a big thing in English Premier League.
Yeah.
So this guy had bilateral club feet at birth.
Okay. Oh, very good.
Yeah. So if a guy can,
play football and become a captain
in the
with,
professional
like,
level, in a
professional
country
level.
like England, I think routine school activities and regular
Should be
exercises
simple.
should not be a problem at all. And this is something which most of the parents tend to miss out on. They think club feet is the end of the world. No, it's not. It's a fairly simple problem.
Okay.
Definitely, does it require intervention? Yes. Is it going to be a long-term intervention? Yes. But at the end of this intervention, will the child be okay? Yes, 100%.
Yeah. No, obviously, because playing sport at a professional level requires so much physical strength, right?
Exactly. And
So,
club
yeah.
feet, it's not like we are talking about Paralympians. We are talking about Olympians who have had problems like this.
Okay.
Steven Gerrard is one such example. That's it. There are so many examples. Like that.
Yeah. No, of course. See,
So
because that is also a thing, right? Like when someone thinks that as a child someone has an orthopedic problem, are they going to be able to play sports?
correct.
Can they live a regular life? Like all of that is like, the parents' main concern.
Exactly.
Because you don't want
So
them to sit in the house and like watch TV or sit in the house and eat and feel depressed. Because if you're not going outside without the vitamin D, like,
yeah, I mean, so many
depression.
other
Yeah,
problems
yeah, yeah.
also come in. The
Yeah.
super added problems are another thing with
Mm-hmm.
children like these.
Mm-hmm.
Mainly, it is the mental as well as the social stigma.
Yeah.
So luckily for us, especially the kids who come to us
Mm-hmm.
for the prenatal counseling,
Uh-huh.
uh, most of the parents, they tend to, go back happily. They continue with their pregnancy,
Okay.
right?
Lovely.
So, and also we have a few support groups also. In fact,
Mm-hmm.
in my clinical practice, I
Mm-hmm.
myself have a WhatsApp group, which consists of all the club feet parents.
Okay.
Yeah.
Lovely.
So we call
Yeah.
them as club of club feet cubs.
Yeah. Oh, very
So
nice. Yeah.
basically, it's a support group
Mm-hmm.
wherein the parents who have already dealt with this particular problem,
Mm-hmm.
they can support the other parents. And
Yeah.
it's a very small, close knit community of all
Of
these
course.
club feet children
Yeah.
who are, most of them are doing really, really well in life.
Oh, lovely,
Yeah.
lovely.
So that is one thing I would like to put across, especially in terms of club feet treatment,
Mm-hmm.
that it is a completely, 100% curable problem.
Okay.
Okay. And that is where, see, club feet is one thing, one
Mm-hmm.
aspect of it. There are so many other genetic problems also for which they come for
Mm.
prenatal counseling. And the importance in of prenatal counseling
Mm-hmm.
is basically, to understand what are the risks associated with
Mm-hmm.
bringing the child up,
Yeah.
and to be mentally prepared for it.
Of course. Yeah.
So that, I think, is very, very important for the parents to understand prior to jumping in the
Deciding.
waters,
Yeah,
if
yeah,
I can
yeah.
say that.
Of
Yeah.
course. Yeah.
So coming to club feet alone,
Mm-hmm.
the second most common problem what I face in terms of my clinical
Mm-hmm.
practice is, they come at 6 months of age or 8 months of age,
Mm-hmm.
saying, "Sir, we did massages, it
Mm-hmm.
didn't become better.
Uh-huh.
Now what do we do?"
Right, right. So how is it then? Like, oh, so they haven't gone to prenatal counseling?
No, no. These kids are usually the neglected ones who probably come from, rural or semi-urban
Uh-huh,
backgrounds,
uh-huh.
and they wouldn't have gotten their initial scans, or it would have
Okay.
been missed at that particular
Yeah.
point. When they are born, they see that there is a deformity.
Mm-hmm.
They assume that it will become better.
I see. Okay.
As and when the child grows,
Mm-hmm.
it might become better. See,
Okay.
um, again, that is where evaluation from a pediatric orthopedic
Yeah.
surgeon is
Yeah.
important, because there is another physiological aspect to this,
Mm-hmm.
which we call as metatarsus adductus.
Okay.
There is the foot would have turned just inwards,
Uh-huh.
and that over a period of time, becomes better as the
Okay.
age progresses.
Okay.
Hmm?
But that you'll
But
be able to evaluate and tell them whether they have to do this
exactly,
intervention or
exactly.
not,
So
right?
I've had so many kids who have been referred to me by pediatricians
Mm-hmm.
who say that this is a club foot, but on
Okay.
evaluation, it will not be a true club foot. It will be more
Mm-hmm.
of a positional problem,
Okay.
and with a little bit of manipulation
Mm-hmm.
exercises, these things become better.
Oh, lovely.
On the other end of the spectrum are these children who come very, very late in their
Yeah.
life, who say, uh, you know,
We thought it would become better.
yeah.
Yeah.
So, see, again, club foot correction, the foot to make it plantigrade,
Hmm.
we can do it at any age.
Okay.
Okay. But the surgeries, they become progressively more and more morbid,
Mm-hmm.
more and
Mm-hmm.
more invasive.
Okay.
So, the earliest or the best time for us to do this treatment
Mm-hmm.
is, we start the plasters after 1 week of birth.
Okay.
Yeah.
Okay.
So that is when we start. So
Mhm.
that early, if we start with the plastering,
Uh-huh.
typically in 4 or 5 plasters, we tend to bring the foot to near normal position.
Oh, lovely.
Yeah. Post that, we'll be having a small surgery which we call as, Achilles tenotomy.
Uh-huh.
Wherein the heel cord, will be doing a small surgery there,
Okay.
and we'll be lengthening that particular part.
Mhm.
And that plaster will continue for the next probably 3 weeks.
Okay.
And post that, we take away the plasters,
Mhm.
and we put them on something called as a foot abduction brace or a steam beak
Okay.
brace.
Hmm.
So in the brace, typically, the treatment is such that initially we'll be putting it 23 hours a day.
Mhm.
That is 6 hours on,
Mhm.
15 minutes off.
Okay.
Okay.
Mhm.
This will be progressively reduced to only night time as well as afternoon time when the
Okay.
child sleeps. That is
Hmm.
when he wears the brace.
Okay.
So the advantage of this, starting early is, like we were talking about the milestones.
Yeah.
By around 3 to 4 months of age is when the child starts, turning, twisting, crawling.
Yeah. Yeah.
If we reach that particular phase by then, wherein the child is putting the braces only when he sleeps in the night and in the afternoon, child is able to do all activities.
Yeah. Okay.
So
if they come a little later, then they're going to have like it'll be longer that they have to
two
put
things
the
happen.
plasters.
One is, because of this, the foot will be more and more rigid. So the number of plasters which are required will become more in an older child. One thing.
Yeah.
Second, because the child is already quite big, maintaining that plaster becomes a big headache for parents.
Yeah.
Okay.
So basically what we're saying is, as soon as you notice that the feet are turning inward a little bit, it is better to get treatment done immediately. Just get it checked actually, not treatment done. And then if it is a club foot, then you can get treatment done. Otherwise also they can give you some manipulation exercises which can help. But the thing is, it does not become better by itself as the baby grows. So it is always better to get evaluated.
100%.
Yeah.
So again, post all of this, the bracing, it typically continues up to 5 years of age.
Okay.
And that is where, most of my parents, they do the problem. They have issues till 1 year of age. The child listens to you.
Okay. Yeah. That's true.
Post that, unfortunately, they start to have a mind of their own.
Yeah.
And they start questioning things. Why should I wear this? And it becomes typically extremely difficult for complying with the brace. Yeah, it's very, very difficult. But unfortunately, it has to be done.
Okay.
So a simple dictum to all parents is, if the child cries while putting the brace and you remove it once, he'll never wear it again. So don't remove the brace just because the child is crying. This is one thing which I would
tell all parents.
100%.
Yeah.
So this is something which unfortunately becomes a problem. Sir, starting mein, whenever he used to cry a lot, we used to remove. Now every time we wear, he cries a lot.
Yeah.
Obviously, right? The child is getting what he wants by crying. He doesn't want to wear that brace anymore. It's as simple as that, because it's restrictive, it's constrictive, it's very difficult for the child to wear.
Of course.
But unfortunately, till they come of a certain age, and the arch typically becomes better and more well formed, it is required.
Yeah, sure.
So in fact, I had a kid who came to me at 4 years, 6 months of age. They were wearing braces very well till 3.5, and post that they were lost for follow-up.
Okay.
After a year, they came back saying, sir, now he walks a little bit funny.
Okay.
The child had to undergo plasters again and surgery again, it became infinitely more difficult for the parents also.
Yeah.
I mean, not more so for a surgeon, for us, we are trained to do these particular surgeries. We definitely get away with doing surgery and, bringing the foot back into its place. Problem happens in, kids who arrive to us extremely late. Typically the ones who come at, say, 9, 10, 11, 12.
Okay.
Those are the children probably who require a little more morbid surgeries, wherein we need to, do some osteotomies. That is, we need to reorient the bones also. So the moment we reorient, when I talk about reorienting the bone, it means breaking of one bone and lengthening of the other, all this sort of morbid procedures, unfortunately, are required at later age.
Yeah.
So dictum is, if at all you see a child with, who you are suspecting a clubfoot, better get them. We evaluate, we see. If it is a positional problem, very good.
Okay.
We'll teach you some exercises, it becomes better. But if it is clubfoot and you neglect it now, you'll be repenting it later.
Yeah, because there's like so much more work involved.
Exactly. So it's hard work, unfortunately. End of the day, it's difficult work for the surgeons also, more so to the parents also. See, it's not just, we just put the plasters in our OPDs and we send them home, They have to look after that plaster at home. It's so difficult. Whereas
if they come at that within the first 3 months, how long does it take to get better if they come the first 3 months?
See, it depends on how rigid.
Usually.
It depends on how rigid the clubfoot deformity is. In supple club feet, we have gotten away with hardly 3 plasters and directly for surgeries also.
Okay, nice.
The worst case, probably, some of these kids also have some associated syndromes with club feet also.
Okay.
It's not just simple club feet all the time, some of these kids have something called as arthrogryposis,
Okay.
and other congenital deformities also present with
Along with the
along with
clubfoot.
club feet. So these syndromic club feet are the ones which probably require long-term plasters, and they are a little more rigid
Complex.
and complex when compared to other
Okay.
simple club feet.
Yeah.
So that is
Okay.
another thing, like club feet itself. In my opinion, if it's idiopathic, very good. If it's just the club foot,
Yeah.
then it's very good.
Yeah.
It's relatively better for us to treat. But usually these club feet children also have to undergo some routine evaluations. Your routine hip screening to
Yeah.
rule out dysplasia of the hip, routine screening of the spine to make sure that there is nothing wrong there. Either a tethered cord or your meningomyelocele and all these things. They all they all are associated with club feet and other congenital anomalies.
Now that you're talking about the spine, how often do you see scoliosis, and how are heavy backpacks and school bags related to that? Because there is a myth, is it true? What is scoliosis?
Okay. See, scoliosis basically means that there is a deformity in the spine, which is usually an S-shaped deformity.
Okay.
Sometimes it's also associated with something called as kyphosis, which is the hunchback deformity.
Okay.
Right. So here, what happens is there will be a change in the anatomy of the vertebra, that is the spine bone, which twists.
So when does this happen?
So again, like I said, they've got multiple reasons. The most common ones are congenital scoliosis, which is
So
unfortunately during birth itself they'll have this particular problem.
Okay.
And second, and a little more aggressive one is something called as adolescent idiopathic scoliosis.
Okay.
So this develops during the adolescent phase, as
Okay.
in when the child is close to around 9 years or 8 or 9.
Okay.
That is when they start having this particular deformity.
Is there anything that they can do to prevent it?
Unfortunately, no.
Okay.
Only thing as parents they can do is identify that early.
Okay.
Okay. And probably get them to your pediatric spine surgeon or a pediatric orthopedic surgeon.
Okay. So how would they identify it?
Yeah. So basically, the most common way in which the child gets identified is either when in a skinny child, especially when they're giving the child a bath, that is when the parents usually see this deformity.
Okay, but what if the child doesn't want to let the parents give bath at like 9 years?
Yeah, those are the ones who typically come when the shoulders start slowly drooping towards one side.
Okay.
And the pelvis starts drooping towards one side.
Okay.
And the child themselves start complaining, that there is some sort of pain in the back, there is some sort of deformity I'm seeing myself.
Okay.
So
Okay.
that is when they usually present to us. Of course, the congenital ones, typically at birth itself, we see that there is some problem. And even then, they get missed out. And they typically come to us by around 1 year of age when the child starts walking.
Okay.
That is when they see, there is some problem in the spine. So
Yeah.
till then, mostly the parents would have either noticed and neglected it, thinking
Okay.
that, again, like I said,
Yeah.
it becomes better
It
with
will
age.
become better. Yes, yes.
Or it is, typically as and when the child starts walking, they see that the child starts walking funny. Because
Yeah.
when there is a mismatch in the pelvic obliquity, they typically have some sort of lurch or some sort of difference in the way they walk.
Okay. So, which is why when parents, when they bring the kids for like vaccination to the pediatricians, right? It's
Oh, yeah.
better to
It's better to evaluate all
to
the
tell them
yes,
all these
100%,
problems if they notice it.
100%.
Yeah.
And see, since these problems are not very, they're more common than what we think,
Yeah.
And typically, when we see this S-shape deformity, there is something called as positional scoliosis also,
Okay.
like, which gets corrected if you bend the child forward. The deformity typically becomes better.
Okay.
Okay, and this is not a true scoliosis. This is something which is positional. Sometimes because
Okay.
of muscle spasm or one of these things, this can happen. But that being said, it's always better to evaluate.
Yeah.
If it's
Definitely.
a true if it's a true scoliosis, it's never just the S deformity what we're talking about.
Okay.
The individual orientation of the bone itself would have changed.
Okay.
There'll be some sort of rotational anomalies also. There'll be some sort of changes in the the anatomy of the bone itself, and that causes problems.
Yeah. No. Of course. Of course.
And typically these are the ones. Again, we tend to calculate the angles of the scoliosis. Typically we see how much of angulation is there, and if the angulation becomes more than 50 degrees, unfortunately, there is nothing else for us to do but to go for surgeries.
Okay.
And mind you, this is not a cosmetic surgery.
Yeah. No,
This
of course.
causes real problems because, as and when the spine grows, it impinges on the organs inside the abdomen as well as
Yeah.
in the chest, typically the lungs, the heart.
Yeah.
So this becomes a problem. It
Mhm.
becomes a functional problem. It's not a
Yeah.
cosmetic problem anymore.
Yeah.
So
That is
that is
true.
where, especially in kids with, the angulation more
Mhm.
than 50 degrees,
Yeah.
it's important for us to go in for surgery.
Yeah. Just I'm sure that most of our audience knows that the spinal cord, like inside you have like your bundle of nerves and then nerves come
Correct.
out from there. So it's an extremely important structure. So if it's bending here and there, it's obviously, so impinging is putting pressure on something. So some of you may have experienced that Saturday night palsy, right? Like when you sleep with one arm up and then it becomes like totally numb. So if you can imagine that's happening to your child, because the vertebrae is like squeezing on one nerve. So it's a little important, and it's not just cosmetic, it is for functional purpose too. Yeah. So we were talking about casts, right? And how, like parents, it's tough for them to manage after 3.5 years.
Oh yeah, it's a big headache.
Yeah. So how can they manage it at home?
See, the simplest thing is basically, make sure that the kid is away from water.
Okay.
That is because most of course, now we have come up with the fiberglass plasters and other things, which typically um, they don't get wet if the water goes from outside. And
Okay.
also we have these newer casts called delta casts, which are washable. Typically,
Okay.
we can just take a bath with the plaster also, nothing happens. But that being said, they're not available at all places. The simplest, the POP plasters what we put,
Okay.
that is those are the plasters which they tend to become either weak or they break.
Yeah.
They become useless.
Hmm.
And to prevent that, the simplest thing the parent can do is basically keep the kid away from water. I mean, again, it's easier said than done.
Yeah, yeah, of course.
The second thing is, the most common problem is typically, especially in the above knee plasters and the high groin plasters,
Okay.
they typically end up with some sort of soiling which goes inside.
Okay.
So to prevent that, I typically advise my parents to, use double diapers.
Okay.
So
Okay.
wear one diaper which is the size of the kid and another probably the next size diaper,
Okay.
so that it is extra secure.
Okay.
So
And otherwise, if something happens to the plaster, they have to come and change it, is it?
it's better that they get it changed, because the
Yeah.
moment it goes, especially the soiling what we were talking about,
Mm-hmm.
if that happens, right, the skin becomes macerated and that causes other problems.
Yeah, because it becomes itchy
It
and
becomes
red
itchy, there'll
and
be rashes, there'll
all
be skin
this.
issues.
Yeah.
Sometimes they end up with fungal infections because of the water. So many other
Okay.
things can happen.
Okay.
So see, the best way to prevent it is, again, even while giving bath, no, we have something called as cast protectors off late.
Okay.
So basically they'll have a waterproof plastic layer which prevents the water from getting inside while giving the bath. That being said, none of these things are 100% sure shot
Yeah.
preventive methods. The only way to do it is, be aware of the kid 24/7, which is
But like you said, you have the parents support group, right?
correct.
So that I think would make like a huge difference.
Yeah, 100%.
Yeah.
They're an amazing group of people, like
Yeah.
even straight from my first child, most of them, they tend to, talk to each other.
Yeah.
They give out advices. There are so many things which a parent cannot ask a doctor all the time.
Yeah, of
and I'll
course.
not be available on phone full time. So what happens is they talk to each other
Yeah.
and they come up with solutions, and sometimes they also
Yeah.
post it in the group. This is what we did.
Yeah, yeah.
So I would like to tell you this very nice thing what happened. One of my children, as and when he grew up, obviously he didn't want to wear that
Yeah.
braces. So they started, they named that brace.
Okay.
They started calling it nighty night brace.
Uh-huh.
So do you want to wear nighty night brace? He used to get so excited to wear that nighty night
Yeah.
brace. Because he just can't.
That's amazing.
Yeah,
Yeah, because
exactly.
if you give it a
So-
name, then it seems so much more exciting, right?
Exactly.
So
And
yeah.
some of them, they tend to give, they have these small dolls, and they make the child put plaster on the doll.
Okay.
So that makes it more relatable to the kid.
Yeah, to the kid.
And see, we at my clinic in HealthFix Orthopedic Clinic, we have these club foot days, typically on Monday mornings between 10 to 1. I run a club foot clinic wherein there'll be parents who get their children, there are multiple kids who are there. They see each other and they see that, okay, this is something which is not, I'm not alone in this particular journey. There are so many other kids who have had the problem. Same thing with the parents. The parents also feel,
they're not alone.
They're not alone. That is extremely important.
Yeah,
especially
it makes like such a big difference, right? Because it's very isolating.
Correct.
Like it's common, but it's not so common.
Exactly. I mean, see, probably in a school you'll have one kid who has this problem. It's not even one class. So that is where, these children really need people who have similar problems like them.
Yeah, like so community support.
Exactly. My point. Yeah. So that is where your, all these, minor initiatives what we have taken, they've helped so far.
Okay. So the next thing I want to ask you about is legs, right? Like they have bow legs and knock knees.
Oh, yeah.
Yeah, like many children actually. So when do parents like notice that? When do they come? What can you do? Is surgery the only way? What are the other things that can be done to support the kids to get stronger, straighter bones?
See, typically how the growth pattern happens, I think that is very important for the parents to know. A child, up to 2 years of age, bow legs is common.
Okay.
Typically the bowing is natural for the first 2 years, and typically from there it slowly starts moving outwards. It starts becoming more towards knock-knee component. By around 4 years is when the valgus angle is maximum. That is the whatever is bowed like this, it becomes there.
Okay.
It goes out.
Okay.
So this knock-knee component happens. The maximum happens by around 4 years of age.
Okay.
And typically by around 5, they come to the adult orientation. Even the adult bones, they are not exactly completely straight. They are, ideally, again, when we talk about anything, we talk about range.
Okay. Yes.
So typically a 7-degree valgus angulation is what we talk about. Valgus is basically just outwards of around 7 degrees. That being said, the normal range would be around 4 to 10 degrees.
Okay.
Anything beyond 10 degrees of valgus would predispose the child to have some change in the mechanical axis. Like I said, although the bones are angulated for that 7-degree angulation or whatever we talk about, the weight bears in a straight line.
Okay.
Correct?
Yeah.
So the typical weight bearing axis of our foot
body
is, it passes just medial to the center of our knee joint. So any change in the angulation changes the weight bearing axis.
Okay.
And that predisposes these kids to have arthritis and other problems at a later stage.
Okay.
Again, when we talk about correction of these particular deformities, it is almost never just cosmetic.
Yeah, of course.
It's always functional.
Yeah.
So why we need to do this particular...
So when is the earliest that they can come to you for a surgery?
In these angular deformities? See, I don't think surgery is the first thing we should think about at all.
Yeah, of course.
So typically when these kids come, we were talking about, how most of these deformities, they happen around the knee joint. Why that is more common is because even bow legs as well as your knock knees, both of them, they happen around the knee joint. The reason why that happens is more than 65% of our limb growth happens around that knee joint. There is that, we were talking about how phases are the growing ends of the bone. So the distal femoral, that is the thigh, the distal thigh phases, as well as the proximal leg phases. Both of them, they contribute to close to around 65% of the total growth of our legs.
So basically, phases is the growth plate that is near like the ends of the bones, which is where the growth happens. Like when it's lengthening, it lengthens at the phases. Right? That is what you're talking about.
So every bone which grows, it grows from the phases. So here what happens is, because the percentage of the lengthening which happens around the knee joint, most of the deformities what we see, they happen around the knee joint. The reason why the most common reason again here is the calcium as well as the vitamin D deficiency.
Okay.
So the first thing we do is basically do a basic endocrine evaluation. We get an opinion of our pediatric endocrinologists. We see that whether this particular problem, whether it by giving sufficient calcium and vitamin D, we sometimes tend to wait up to even 6 years of age also.
Okay.
But again, individually, it depends on case basis.
Yeah.
Ideally, 5 years, post 5 years is when I would particularly like to intervene.
Mm-hmm.
What we can do there is basically we do something called as temporary hemiepiphysiodesis.
Okay.
So what we do is, typically say there is a knock knee.
Mm-hmm.
The knees are like that,
Yeah.
and the inner end of the bone, when we split the physis into two halves, right? The inner half of the physis, that will be growing faster when compared to
Okay.
the outer half of the physis, right?
Yeah.
So what we do is basically we put a small plate there, which is called as an 8 plate. Okay, so it tends to arrest the growth of the physis on one end.
Okay.
Okay, as and when you arrest the one end of the physis, the other end grows naturally,
Yeah.
and the deformity corrects by itself.
I see. Okay.
It's a beautiful, simple procedure.
Yeah.
It tends to take care of this problem, by and large.
Okay. Lovely.
Okay. Along with that, definitely, if at all there is any endocrinal anomalies, we need to take care of that also.
Okay.
And,
For
typically,
example.
again, calcium, sometimes there'll be parathormone deficiencies.
Okay.
So all these things can predispose the child to have this particular problem.
Yeah.
So once the evaluation happens, typically we tend to start them on just the simple calcium and vitamin D, or many a times, the endocrinologists, they tend to take a call on how best to approach this particular child. So from the surgical perspective, this particular surgery is extremely important to be done, during the growth phase. Yeah, at the correct time, because once the physis closes, and we need to do this particular surgery, we don't have this luxury of, just the small surgery wherein, it's so beautiful that these 8 plates, right? We operate the child on the previous day, and the next day the child is up and about. In fact, they're running in the wards.
Yeah.
It's so
simple and easy. Yeah.
And absolutely no, morbidity is extremely less when compared to a big surgery like which is required once the physis closes.
Okay.
If the physis closes, that angulation has to be corrected surgically by either doing osteotomy, which is an opening wedge or a closing wedge osteotomy, depending on where the particular problem is. So when we talk about osteotomy, we talk about, surgically, breaking the bone and realigning them in the right place. So that becomes an extremely more morbid surgery when compared to a simple small.
Just putting this 8 plate.
Getting a small 8 plate, And once the deformity gets corrected, we take away that 8 plate and the child starts growing normally.
Oh, lovely.
Yeah. It's a very simple, easy and effective procedure.
Yeah. Okay, so that's really nice. So for parents, like if they notice these like knee deformities, till the age of 2, it can correct itself. But after the age of 2, it's better to go and just, have a consult, see if it can get better or not. And if they want to get surgery done, it's better to get it around the age of 5 or 6.
Yeah.
Because that is when it's malleable.
Correct.
Yeah.
And see, again, at any point in time, there are certain alarm bells which for some parents it happens a little early. Instead of having that anxiety in mind, better to consult.
Better to consult.
It's important, Like what happens is most of these kids, they, especially like we were talking about how the nuclear families have only one child. Most parents will be extremely anxious when they bring their children to the clinic. So, instead of going through that anxiety, it's important for them to understand. That is the reason why this podcast becomes so important,
Yeah. It's easy to manage.
Exactly.
Yeah.
So
Not
this way they know, when to approach, how to approach, and whether to approach.
Yeah.
So for me, at any point in time, if at all, see the other point, especially with bow legs itself, probably we would not be doing anything. But if at all, when the child comes to us with bow legs, we also evaluate for some other features of nutritional rickets. When there is a deficiency in calcium and vitamin D, we call that rickets. Right?
Yes.
So this other features would probably, something to be aware of as parents. One is there is something called as frontal bossing, wherein there will be bulging of the front of the skull.
Yes.
Second is, the ends of the bone typically they become slightly widened when compared to a normal child.
Yeah.
Of course, there is a little component called pot belly and rachitic rosary. So many other things are there, but the simplest things for the parents to observe.
Do parents miss it?
Yeah.
They
More
do?
often than not, yes.
Yeah, even the frontal bossing and, the widened like epiphysis.
They just say that we thought it is normal.
Okay.
The problem here, again, like I said, no, they don't have they usually have seen one or two kids in their lifetime.
True.
They just assume that it is normal because the child doesn't show any other symptoms.
Okay. Yeah, like they're able to talk properly, walk and do
Yes,
everything. So
yes.
they probably think that they don't want to
Apart
fuss
from
over
bowing,
something.
yeah, once the bowing sets in, that is when they tend to come. Arey
Okay.
sir, there is some problem in my child.
Mm.
There is slight bowing. And when I see there is all these features of rickets, and when I ask them whether they have observed all this, they would be like, we thought they're normal.
Okay.
So,
Okay. So these are not like normal. We'll probably like add one list of what is seen in rickets because they're very common and maybe we don't realize them, like the frontal bossing, the widened epiphysis, the bow legs, right? All of this is common but not brought to the doctor's notice in the beginning. The thing is, if we notice it before, then we're able to give you the nutritional support which you need to prevent this from becoming a permanent issue later.
and definitely when we give nutritional
Mm-hmm.
supplementation, more often than not, nature tends to take care of the problem.
Lovely.
So we would not require surgery at all.
Yeah.
Yeah.
Okay. So that's so much better for the parents also. Like they don't need to
Exactly.
go through that stress and anxiety, right? Yeah.
So probably food for thought.
Yeah. Okay. So most of them, they're usually scared when you say like surgeries itself, right? They're like, oh my God, you need to go in for a surgery, and then there's anesthesia, and then there's like post surgical like issues, like post surgical infections and everything, right? And yeah. Now we need to talk about adolescents too. So which would you prefer? Talking about adolescents first or these infections first?
I think infections we would cover here.
Yeah.
Yeah, see, because infection is one thing which becomes a true and dire emergency in kids.
Okay.
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 Neglected infections, we have seen, they create havoc.
Okay.
Hmm? Um, so basically, most of my kids' parents, they're apprehensive of going in for surgery.
Okay.
Typically, especially in osteomyelitis, which is the infection of the bone,
Okay.
and septic arthritis, which is the infection of joints.
Mm.
The sooner we intervene, we tend to prevent complications.
Okay, so parents would like to know, like, does this happen often? What are the signs? When should we
See,
come?
the simplest sign in a walking child is limp.
Okay.
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 And typically an unexplained fever which has been treated by the pediatrician first, and if it is not reduced even after sufficient dose of antibiotics, that is when usually see, especially these osteomyelitis and septic
Okay.
arthritis pictures, right? They are brought to notice, by the pediatricians rather than the parents.
Okay. Okay.
Okay. So typically how they present is, they go to the pediatrician for the fever. The pediatrician tends to get the investigations done.
Okay.
They show signs of bacterial infection, and they tend to treat it, assuming that there is some sort of either a chest infection or septicemia, one of these things, and they start giving out antibiotics. Even with antibiotics, sometimes these things don't get better, and that is
Okay.
when the alarm bells start ringing. That is when they check the limbs.
Yeah. Yeah.
Till then, usually, the kid is resting because it's tired from the
Yeah.
fever. That is how
Absolutely.
usually the parents also think, and the pediatricians also.
Yeah.
Right. So what happens is here, the attitude of the limb is one thing which probably should start
Warning bells.
Warning bells. Yes. So typically, what happens in a infected knee and a hip is basically the child keeps the limb in a flexed attitude.
Okay.
Because flexion gives us more space.
Okay. Okay.
So the hip is bent, the knee is bent, and the child typically starts crying the moment you start moving the limb.
Okay. Okay.
So starts wailing when you start moving the limb. So that should set the alarm bells off.
Yeah.
Right.
Osteomyelitis.
So typically what happens then is, we tend to see the extent of the infection.
Okay.
So the extent of the infection, to see that, unfortunately, we need to get a few investigations, including MRI and X-rays. So these give us the exact picture of whether there is infection and what all is involved, whether it is just the joint or the bones also.
Okay. Okay. So, like, say they've come to, they've gone to the pediatrician, they have like an infection, they've given like paracetamol, first day, didn't work, then they started antibiotics. 2 days it hasn't worked, right? See, usually they give 3 days to 5 days antibiotics. But the fever should at least come down after the second day. Like, say it's not coming down after the second day, can they go for an MRI at that time? Or do we still wait till 5 days? Like, let the child go through that?
I think it differs on an individual case on case basis.
True.
But that being said, it is always better that the pediatrician takes that call. And more
like earlier?
importantly, yes, if you have an access to a pediatric orthopedic surgeon, it is better that they give a pediatric evaluation,
Okay.
an orthopedic evaluation also, so that we don't miss out on this particular
Okay,
issue.
so you can catch it earlier?
100%, because the moment we start moving the joint, like I
Okay.
said, if there is any sort of see, basically when we talk about osteomyelitis and septic arthritis, what happens is there will be accumulation of septic fluid inside the joint and the bones. So this causes severe pain.
Okay.
So the moment we start moving the child starts wailing in pain.
So they'll be able to check before itself.
Yes,
with this
the
pain.
moment we do the orthopedic examination, we know whether it seems like a bony infection. Yes,
Yeah.
at that point, typically we start out with ultrasound, because it's not very easy for a child to go through the MRI.
Yeah.
Because they have to lay still for more than half
Correct.
an hour. So many a times, more often than not, they'll require sedation also. So so that is where we tend to go for either an MRI or an ultrasound, just to do the preliminary examination. Ultrasound is more than sufficient.
Of course.
In ultrasound, if we are able to pick up something, it is worthwhile to go in for MRI.
Yeah.
MRI gives us two things, to whether it is just the infection is there or not, and second, what is the extent of the infection, whether it is involving the joint, bones, and till what extent do we need to clean it up. So, and see, at that point, if I've seen so many parents hesitate for surgery. Unfortunately, in our day-to-day practice, if at all there is a septic arthritis, we need to open the joint and we need to drain it out.
Yeah, of course.
So there is no other way around it. So we have seen kids as early as 4-day, 5-day-old child with septic arthritis of the joint.
Okay.
And unfortunately, we have to open.
See, as parents, I'm sure the parents would want to know, is there a way to prevent this? Like, what is the cause?
See, how there is no prevention of viral infections, or there is no unfortunately nothing much the parent can do, apart from while especially these are the kids who are usually breastfeeding.
Okay.
So the one thing is probably keep your nipples clean.
Okay.
That is one thing which would definitely go a long way in prevention of just these simple infections that tend to become worse over a period of time.
Yeah.
Any infection for that matter. And second thing is, I think for the mother it's important that the mother has a good diet pattern, especially high protein, high calcium diet.
Okay.
And that, what you eat goes to the baby.
Yeah.
Right? So that tends to help the baby develop good immune system.
Okay.
And that is what is going to help in the long run.
Yeah.
Typically in such children who end up with these septic hips and bone infections, they are premature kids.
Okay.
They are more predisposed to such problems, unfortunately.
Yeah.
Because their immune system is not that well developed when compared to a fully grown baby.
Yeah.
So they are the ones who are more prone for this particular sort of.
So basically, you need to be like more careful when it's a premature, like a neonate infant,
yes. Unfortunately,
right? Like with all like the cleanliness and everything. Okay.
So yeah, again. If at all it is an established osteomyelitis, if at all it's an established septic arthritis, my sincere request to all parents is do not hesitate for the surgery. Yeah,
like don't delay it.
Because what happens is it's extremely difficult to treat that particular problem.
Okay.
And typically what happens is, if at all, I've seen kids with post-septic sequelae, they end up with a completely destroyed joint.
Yeah.
Who have to undergo more morbid procedures at a later point in time.
Yeah. So better to just, like drain it and leave it. Yeah.
It's like, the room is on fire.
Yeah.
It's a closed room which is caught on fire. So the debridement makes sure that the fire is doused out.
Yeah.
Otherwise the fire keeps on damaging.
Yeah. Okay. No, so yeah, because parents find it very difficult to make that decision, right, at that time, because it's a small baby and they're like surgery, like people are generally like afraid of surgeries because, okay, so I feel like people have heard of many post-surgical like morbidity cases, Morbidity means like, either death or like not comfortable scenarios. And because you've heard one or two, you assume that everything is the same. But there are many people who have had many surgeries and who are like living very comfortably. So even if it's a very young child, and no doctor would want to advise, you know, to do a surgery on a small child ever. None of us want that, because we are like, it's a small child at the end of the day.
We
Unless,
are more scared than the parents.
yeah, actually, because we are responsible. If we are saying like get a surgery done, we are responsible for it, right? So in case we have left all that safety and we are saying take a surgery, it is usually um, for the betterment of the kid. That's about it, right? Because I feel like
100%.
that's what they're scared about, because they're like, okay, is it really necessary? Is it really necessary is the main question.
See, more often than not, the parents are worried about anesthesia rather than
Uh-huh.
the surgery itself.
True. Yes.
So they think, anesthesia will cause some problem
Mm-hmm.
or some permanent damage to the brain,
Yeah.
this, that. So many myths around it.
Yeah.
Um, so, see, off late, again, like we have pediatric orthopedic
Mm-hmm.
surgeons, we have pediatric anesthetists also.
Mm-hmm.
You know, so that one particular advantage of having a
Mm-hmm.
pediatric anesthetist is basically they deal with just the kids, like how we
Yeah.
deal with just the kids and their
Kids.
bones. They deal with kids and the anesthesia to the kids.
Yeah.
So that way, I think subspecialty wise,
Mm-hmm.
it's a little more safer if we have a pediatric anesthetist in house.
Of course.
But that being said, anesthesia itself is not risky to the baby at all.
Yeah.
When it is needed,
Mm-hmm.
and we defer the surgery for whatever reason,
Yeah.
it becomes infinitely more complex for us to deal with it at a later point in time.
Yeah. Yeah. No, of
So
course.
instead,
Mm-hmm.
do the surgery at the right time when it is
Yeah.
indicated,
Mm-hmm.
and typically we tend to get away with these problems.
Yeah. Yeah.
Yeah.
Yeah. No, of course. So osteomyelitis, when is the later stage that you see it in? Okay, these like newborn, like premature kids.
Oh, infection can happen at any point in their lifetime.
So why is it happening? Because if they want to prevent it, because infection is definitely in the bone, osteomyelitis is not viral, it's bacterial. So say they want to prevent it and be like more careful.
See, most of these kids are typically malnourished kids with some
Okay.
sort of immunocompromised status.
Okay.
Okay.
Hmm.
So a healthy diet and regular exercise goes a long way in prevention of these problems.
Okay. Okay.
Okay. So, whatever said and done, if at all the infection sets in,
Mm.
um, we have to take care of the infection. Okay?
Yeah.
But we have seen, in some immunocompromised children,
Mm-hmm.
multiple joints get infected at multiple stages, at different stages in time.
Hmm.
And they happen all the way up to the child's maturity.
How would the parents know if the child is immunocompromised?
So that is the thing. If a child is having, more than 2 episodes of fever in a
Mm.
month,
Mm.
uh,
Okay.
and consistently for more than 3 months, was
Okay.
the thing.
As in very frequent fevers, then you can suspect that the
Yes,
child is
so
immunocompromised.
correct.
Hmm.
So at this, these are the children who probably, end up with higher risk of bone and joint infections.
Okay.
Yeah.
Okay. Yeah. Okay. So now that we've done bone and joint infections, adolescents, what should parents know? Like what are the things, like, okay, see, like say tight shoes. Tight shoes cause like hallux valgus. Hallux valgus is your toes going like this, right?
In
Or
huh,
yeah.
huh.
Or is it what is it about shoes and bags that adolescents should know? Because everyone is like, oh yeah, like the kid is like hunching because of like the heavy bags. They're like carrying too many books. So what should we know about
So
these things?
yeah, one thing is, if the child is strong enough,
Mm-hmm.
typically lifting bags should not be a problem.
Okay.
That being said, see, heavy bags,
Mm.
I mean, as and when we move towards a more digitized world, I think
That's going to
bags
reduce.
the
Yeah,
books are
yeah.
going to get replaced by pads, and, I
Yeah,
think most
laptop.
of my
Mm-hmm.
fellowship books are in pad now, that we
Yeah.
don't have.
But I really like books just to highlight.
Yeah, fair enough.
Yeah.
I mean, now they have highlighters in PDF readers also, that
Yeah,
is.
yeah, but it's different when you're the sound.
I know. There's a different feel to it.
Yeah. Huh.
But that being said, when it comes to the shoes,
Mm-hmm.
typically, barefoot walking is supposed to be better for the
Okay.
kid in
Mm-hmm.
terms of, see, walking is not just about moving from one place to another. It is also about having a proprioception, that is
Yeah.
where my foot is and
Yeah,
the
yeah, yeah.
orientation of the entire body,
Mm-hmm.
and as well as the sensory inputs.
Yeah.
The child walks on different surfaces.
Mm-hmm.
There is a lot of these neuromotor development which happens
Mm-hmm.
especially in the early age.
Okay.
So we have seen that kids who walk bare feet,
Mm-hmm.
they tend to have stronger development overall
Okay.
in terms of
Mm-hmm.
neuromotor development. That being said, a simple footwear is
Mm-hmm.
always advised, because of so many reasons. Because see, indoor it's easy for us to say, okay, walk barefoot. The moment
Yeah.
the child goes out of
Yeah.
the house, because of so many reasons, we cannot have a child walking barefoot.
I mean, like now that we said proprioception, so before I forget the question, seen many patients coming, like they had like when they had kids before, they said that iPads were bad and all of that. So they used to watch TV and everything. Their proprioception is slightly skewed. Have you noticed that?
I mean, yes.
Yeah,
I don't know whether it is directly correlating to this particular thing, because I mean research is still
going on.
going on about it.
Yeah.
But that being said, a lot of behavioral issues definitely has been proven in kids who have been.
Yeah, but this proprioception as well, like between the age group of like say 14 to 10, currently 14 to 10, right? Because that's when like all these TV songs, everything like first came out. So it was very easy to make them sit in front and eat it, like food or whatever. So the proprioception was lesser, not just in one or two children, like many children, like they don't know where their foot is going,
Uh-huh.
and it was very fascinating. We like gave them like some exercises, like
So-
like you like go on your toes, that
Correct,
thing,
correct.
and then that became a little better.
They
But
do, I mean, your occupational therapists as well as physiotherapists, they
mhm.
tend to do something called as gait training.
Yeah.
Okay, especially in children with cerebral palsy and these
Mhm.
neuromotor development
Yeah.
issues. They tend to make them walk on different surfaces.
Yeah.
Uh,
No, so these guys don't come. These like TV, iPad watching guys, they don't
mhm.
go to the
No. I
physiotherapist.
don't think they've ever.
They don't. But they have this because I've seen this in at least like 10 children, right? Like they don't know where the feet is going, suddenly they trip and they fall. And it's actually quite common. More common than we
I
think
mean,
it
I'll
is.
have to go back into this.
Yeah, because they're not coming for surgery, right? It's just
Correct.
one simple
Correct.
lifestyle
Correct.
disturbance, if you could call it. So, I mean, it becomes better after age,
Mhm.
but there's a proprioception issue.
Again, most of this, when
Mhm.
coming back to this barefoot
Yeah.
walking, no. So what happens is basically the sensory inputs what they get when they
Mhm.
walk on different surfaces.
Yeah.
That is supposed to help in the general neuromotor development also.
Mhm.
So typically, probably the ones with these iPads, what we were
Mhm.
talking about,
Mhm.
this is just my theory. Whether these kids have that sufficient exposure or not, that becomes a big question mark.
Yeah. Because they're
So-
sitting most of the time
Correct.
then.
Correct.
Mhm.
That being said, like we were discussing,
Mhm.
going out of the house barefoot is probably not advisable, especially in our country.
Yeah,
Uh,
true.
so probably designated play areas,
Mhm.
where in the ground, which
Yeah.
is reasonably safe,
Mhm.
on your lawn,
Yeah.
if at all you
Yeah.
have access to things like this, or in
Mhm.
your terrace, balcony, whatever
Mhm.
you.
Mhm.
So there, if the child walks on different surfaces, on rock, on
Mm.
mud
Mm.
and grass,
Mm.
that tends to help the child in general. But
Okay.
that being said, footwear itself, is not a problem at all.
Okay.
So
Okay.
footwear is safe.
Okay.
That being said, uh, footwear has to be, a flat footwear.
Okay.
Heels probably not a good idea in kids,
Mhm. Mhm.
right? And constrictive footwear definitely not.
Okay. Okay.
So constrictive footwear typically tends to cause more problems than no footwear.
Okay. So, how often do they have to change their shoe? And is
Uh,
loose footwear bad?
No, I don't think loose footwear is bad. It's just that loose footwear takes a lot of effort to walk, because
Okay.
you
Okay.
tend to hold the footwear in your this
Uh-huh.
one. So I think the appropriate size is what would be recommended. Kids typically grow in phases.
Okay.
They
Mhm.
don't grow for a period of time and then they
Mhm.
suddenly outgrow
Yeah.
everything. That is
Yeah.
how typically the
Mhm.
kid grows. During their growth spurts, yes, they would like, I
Change
would
the
like them
size.
to change their
Mhm.
sizes as and when. Um, At any point in time, if it is difficult for especially the school shoes,
Yeah.
that is the most important marker,
Yeah.
because every day the child wears the school shoes.
Yes.
So at any point in time, if it starts getting a little tighter,
Mm-hmm.
it is worthwhile to just change it rather than
Yeah.
continuing with it, thinking
Mm-hmm.
probably one more month and then we change. That's not probably a good
Yeah.
idea.
It's better to change
Yeah.
it immediately. So adolescence, you were talking about adolescence. What do you see in adolescence, and what should parents know about adolescence and bone health?
See, in terms of adolescent bone health itself, right?
Mm.
Probably, as and when the child grows and
Hmm.
starts having a mind of their own,
Hmm.
it is very difficult for parents to convince the kids to follow that good diet and
Mm-hmm.
that regular exercises.
Mm-hmm.
Two things happen. One is, as and when they grow, their uh, studies, they become more and more competitive, and
Okay.
it becomes more and more difficult for the child to cope up with the school itself.
Mm-hmm. Mm-hmm.
uh, I mean, I'm not talking about the brilliant ones, I'm talking about the
Of course, those who need
mass.
to study.
Yeah.
Yes, yes.
So because of that, they tend to take a lot of pressure on themselves in
Okay.
general,
Hmm.
and that is the time when your hormones, they go on a toss,
Yeah,
right?
because already you're going through adolescence.
So because of
Hmm.
that, there is a lot of these behavioral issues which come into play.
Okay.
Okay, so that is where I think a supportive and an understanding parenting becomes extremely
Mm-hmm.
important.
Okay.
So rather than asking the telling the child to
Mm-hmm.
do something,
Yeah.
you know uh, understanding what they're going through, probably
Mm-hmm.
having an open talk,
Uh-huh.
that would definitely go a long way in understanding the problem, one thing.
Yeah.
And second is, typically in adolescent kids,
Mm-hmm.
these deformities, as and when, if at all,
Mm-hmm.
the
Yeah,
most
yeah.
common things what we see is, one is the spinal scoli, as well as
Okay.
your your knock knees and bow legs and this sort of
Okay.
deformities.
In adolescence.
Yes, yes.
Hmm.
So sometimes it begins late.
Okay. Hmm.
It begins late. See, growth spurt, at any growth spurt, if the
Uh-huh.
calcium and vitamin D deficiency
Mm-hmm.
occurs,
Mm-hmm.
or because of an overweight
Mm-hmm.
issue,
Mm-hmm.
the child can develop angular deformities at any point in time.
Okay.
Yeah.
Okay.
And adolescent idiopathic scoli is a completely different topic on its own. Like
Mm-hmm.
it's a big thing for especially the ones who deal with routine spine surgeries.
Yeah.
Dealing with adolescent idiopathic scoliosis is quite challenging, because
Okay. Like,
they develop quite rapidly.
yeah,
It's
because
a
you're
fast
saying
growing
it's
curve.
idiopathic,
Yeah.
so they're not going to know when it comes. So, like, say a kid is watching this, adolescence would be like what, 12 years old?
Yep.
Okay.
So
Then
9 to 12 is when they
9
typically
to 12.
present. Yes.
So, that time they'll notice like if his shoulder goes down or, gait is not comfortable.
Better to approach your parents.
Okay.
Yeah.
Okay.
Than to an orthopedic surgeon.
Okay.
Typically.
Yeah, yeah, parents, so you can just show your child like this part of it. If anything is different in the way
Yeah.
you walk or the way you're, feeling, please tell us. Right? You can tell them that. Yeah. So, yeah, because it's always better, like the earlier you know, the
Correct.
easier it is to treat.
100%. 100%.
Hmm.
Yeah.
Knock knees and bow legs in adolescence.
Yes. It
Okay.
can develop at any point in time.
Hmm.
Till the child's growth is complete.
Yeah.
Knock knees and bow legs can happen at any point in time. So
Okay.
we should not be neglecting these things, saying
They
very
become
typically,
older.
yeah,
Yeah.
as and when they grow, it becomes normal.
Mhm.
It may,
Yeah.
but more often than not, it doesn't.
Okay.
Yeah.
Okay. Like, say they get bow legs or knock knees at like say 9, and say you correct the vitamin D and calcium like deficiency. Do they get better?
At this age, probably I would not risk it, because when
Mm.
we were talking about how
Mm.
easy it is for us to correct it with an 8 plate,
Correct.
and
Correct.
how
Correct. Correct.
osteotomy
Yeah.
becomes infinitely more
Yeah. Yeah. Yeah.
complex.
Mm-hmm.
So that is where
Might as well
um,
put the 8 plate.
it's faster,
Okay.
it's easier.
Mm-hmm.
Yeah.
Yeah.
Mm.
Okay. Fair. And they'll still have the calcium and vitamin D supplementation.
Of course, 100%.
Hmm.
The nutritional, see, it's like how we correct the foundation. It's
Hmm.
not just putting the foundation right. It's also about maintaining that particular.
Yeah.
That is where your calcium and vitamin D supplementation come into picture.
Yeah. What were you saying about biphosphonates? When do we give it?
Bisphosphonates basically in these endocrine anomalies, especially in osteogenesis imperfecta, brittle bone disease, and all these things.
Okay.
Do we go there?
Mm-hmm. Yeah. So how do we see that? Like, do they commonly occur?
See, this is a reasonably rare issue.
Mm-hmm.
We typically a child with frequent fractures. That
Okay.
is how they usually present to us in the clinic.
Okay.
So
Okay.
my child had more than 3 fractures in the past
Okay.
year. I
Mm-hmm.
don't know what is wrong. We
Okay.
have given calcium, we have
Mm-hmm.
given vitamin D. We don't know what is happening.
Mm.
That is how a concerned parent usually presents to us.
Okay.
Then, when we look at the bones, we see that it is more osteoporotic,
Okay.
basically,
Mm.
when compared to a normal child.
Yeah.
And then, typically these kids present with some other non-specific findings like a blue sclera in some
Okay.
kids.
Mm-hmm.
You know, it all depends. There are osteogenesis imperfecta is something which is routinely called as a brittle bone disease.
Okay.
Okay. In severe forms, we have children who have fractures during childbirth, and
Uh-huh.
they tend to, not survive.
Okay. Mm.
But the ones who do, they typically, in milder forms of osteogenesis,
Mm-hmm.
they usually do well at a later stage in life. But
Okay.
initially, as and when the child grows,
Mm-hmm.
they tend to have a lot of fractures.
Okay. So when they
So,
notice, like, I mean, like 1-2 fractures in a year is not common. So in case that's happening, they should probably come and, like consult and find out what's happening, because treatment can be given to reduce the number of times that the fractures are happening. Reduce. It will still happen, but not as much.
not
Right?
just that, untreated
Hmm.
osteogenesis, it also tends to cause bowing of the bones.
Okay. Hmm.
We tend to have something called as a shepherd's crook deformity, at
Okay.
the
Yeah.
proximal femur,
Mm-hmm.
wherein the entire bone becomes completely bowed like that. It becomes crooked.
Uh-huh.
Okay,
Uh-huh.
so to treat that, it becomes infinitely more complex for even a pediatric orthopedic surgeon.
Yeah.
Somebody who's trained in doing these surgeries
Mm-hmm.
also. They're not simple, straightforward surgeries.
Yeah.
So
Of
to
course.
correct these things, it becomes extremely difficult.
Mm-hmm.
This happens because of untreated multiple fractures, which
Okay.
over a period of time malunite, and over a period of time
Yeah.
it causes that bowing of the legs.
Yeah.
This is a completely different thing from what we were talking about. The bow
Yeah.
legs and
The
your
other
knock
bow
knees.
legs, that is completely
It is
different.
totally different.
This has repeated fractures also.
Correct.
Like, that's very important.
Correct.
Hmm.
And typically these kids, once the bone breaks, it
Mm-hmm.
tends to unite well.
Okay.
Only thing is, it unites in the wrong place, and that is what causes the issues. One thing,
Mm-hmm.
and second thing, to the number of fractures,
Mm-hmm.
it definitely can be reduced by giving bisphosphonates.
Okay.
We give 6 monthly injections of
Okay.
something called as zoledonic acid.
Mm-hmm.
So basically, when we talk about bone, it's
Mm.
not like a cement structure which you know
Yeah. Yeah.
which is there throughout the life. It's a living tissue.
Mm-hmm.
Okay, every day there is deposition of calcium,
Yeah.
and every day there is absorption of calcium also.
Mm-hmm. Mm-hmm.
Okay, so when we give calcium and vitamin D supplementation,
Yeah.
we increase the deposition of calcium in the bones,
Mm-hmm.
and there are some medicines like bisphosphonates
Yeah.
which tend to prevent the bones from getting resorbed. Calcium from getting resorbed from the
Yeah.
bones.
Yeah.
Okay, so we are improving the deposition of calcium,
Mm-hmm.
reducing the absorption of calcium
Yeah.
from the bones.
So
Right?
maintaining it in the bones,
Correct,
basically.
correct.
Hmm.
So that becomes an issue in most of these kids, and
Okay.
many of these children also have some other genetic defects, also some endocrinal anomalies,
Mm-hmm.
some problems in the kidney. All
Okay.
these things can predispose them to have weak bones.
Mm-hmm.
Okay,
Mm-hmm.
it's not always just the calcium and vitamin D
Yeah.
deficiency, as we were
Of
talking
course.
about.
Yeah.
So it's important for parents to actually get to the root cause
Mm-hmm.
of this
Mm-hmm.
particular problem and get it treated, so that at least we can maintain the strength of the bone,
Yeah.
prevent the number of fractures,
Mm-hmm.
not just in osteogenesis, in
Of course.
all these brittle bone diseases,
Mm-hmm.
what we were discussing about. It's important to understand the cause, and that is where sometimes in the kids who actually require them, we
Yeah.
also get some genetic tests done.
Okay.
Mm.
Hmm.
So we tend to see what exactly is causing this particular problem, whether
Mm-hmm.
it is preventable, whether anything can be done,
Yeah.
and how well we can protect the child from having fractures at a future point in time.
Of course.
Right? Uh, if it is a plain osteogenesis,
Mm-hmm.
as and when the child grows, although the bones are still not completely strong,
Mm-hmm.
the number of fractures progressively become lesser as and when the child approaches adolescence and adulthood.
Okay. So flat feet. That is something that we
Oh, yeah.
commonly see these days.
I mean, it's always been there. Now
Mhm.
we are more worried about flat feet, Like
Okay.
more than 90% of the flat feet is physiological. It's normal.
Okay.
Okay. So there are different components to flat feet.
Mhm.
One end being completely physiological,
Uh-huh.
the other end being completely, the reverse of what the foot arches are supposed to be.
Okay.
What we call as rocker bottom deformity.
Mhm.
Okay. So what happens there is basically, there is something called as a vertical talus.
Mhm.
Talus is the bone which articulates at the ankle. So
Okay.
the ankle where our leg articulates
Mhm.
with the foot,
Yeah.
it articulates with a bone called talus or
Mhm.
talus.
Mhm.
So this bone, it's more vertically oriented when compared to a normal
Okay.
orientation.
Okay. So
So
regularly the orientation is a little upwards.
it's a little downwards itself. It's
Okay.
approximately around 15 degrees downwards.
Okay.
But here it will be almost 60, 70 degrees down.
Okay.
Okay.
Okay. Hmm.
Uh, so because of that, what happens is there is a dislocation of the joint where it is supposed to articulate in front, which is
Mhm.
called the talonavicular joint.
Okay.
Okay. So that results in skewing of the arch.
Okay.
Okay. It becomes reverse.
Okay.
So this is the other end of the spectrum.
Mhm.
Okay. Most of the kids who present to us will be somewhere in between.
Okay.
So
Right.
it's neither completely physiological nor
Mhm.
completely vertical talus.
Okay.
They present with something called as an oblique talus deformity.
Okay. So what can a parent do at this point?
See, in flat feet, typically in children, right, because the ligaments are quite lax,
Mhm.
usually flat feet is quite commonly seen till the age of, say, around 5.
Okay.
Okay. But, it should never be painful to the child.
Okay.
So if
So if it is
flat feet is
painful.
associated with
Mhm.
foot pain,
Mhm.
that is when you should approach the doctor.
Okay.
One thing.
Okay. Mhm.
Second, not just the flat feet. Sometimes what happens is there will be the hind foot, right? As
Mhm.
in the heel bone, that is the
Yeah.
calcaneus, what we call.
Mhm.
The heel bone is normally oriented at around 7 degrees of valgus angulation.
Okay.
Okay. That angulation sometimes becomes more.
Okay.
Okay.
Mhm.
So this particularly ends up with deformity called calcaneovalgus deformity.
Okay.
Okay. Wherein the hind foot is completely outwardly turned.
Mhm.
Because of that, the foot will be turned outwards
Mhm.
with a small bump seen on the inner aspect of the foot.
Okay.
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 So this deformity again would require some sort of intervention.
Mhm.
Typically, we start with if it's a painless foot,
Mhm.
we tend to give medial arch supports.
Okay.
Okay. We see that the foot at least aligns well with the arch support.
Okay.
First of all, during examination, we check
Mhm.
whether the arch is reforming or not. That is a
Okay.
very good indicator for us.
Mhm.
And definitely, we do a few X-ray imaging
Mhm.
wherein we check what is the orientation of the angle, whether the joint is getting dislocated or subluxated.
Okay.
All these things we'll get a
Mhm.
picture by doing different views.
Yeah.
So once that is done, we typically come to a conclusion as to what exactly is the underlying problem.
Okay.
So more often than not, with medial arch support, these
Mhm.
things tend to become better.
Okay. Lovely.
But some kids will require a step further,
Mhm.
wherein we give something called as a supramalleolar orthosis with a medial arch
Okay.
support.
Mhm.
So this tends to stabilize the hind foot also,
Okay.
and that tends to become better as the kid grows.
So it's more comfortable for them, basically.
Not exactly more comfortable; it's
Mm.
more rigid when compared to your medial arch.
Okay.
But that
Huh.
being said, it's unfortunately required in some children. Again,
Okay.
it
Okay.
depends on individual and case on case
Because of like
basis.
weight bearing and all of that.
Correct, correct.
Okay.
And especially in these painful flat feet,
Mhm.
that is where we end up doing some sort of surgery. Okay.
Okay. Yeah.
Either we put a small implant in the subtalar space
Okay.
to get the
Mhm.
arch back,
Mhm.
or in rigid cases we tend to go for calcaneal lengthening osteotomy is what we do,
Okay.
wherein we lengthen the you know outer border of the foot,
Mhm.
shorten
Mhm.
the inner border of the foot,
Yeah.
and do some magic with tendons.
Yeah. Yeah. So
Yeah.
that
So
yeah.
basically, we shorten some, we lengthen
And
some.
lengthen some
Yeah.
exactly.
So
Hmm.
all these things we do.
So that's more comfortable
Um,
for the kid.
yes. So that
Hmm.
we get the joint back in place,
Yeah.
especially
Yeah.
in the talonavicular dislocations,
Mhm.
subluxations. It's important for us to have the joint back in place, or else
Yeah.
in the long run they end up with
Different kinds
arthritis
of
and
pain and
intractable
arthritis.
foot
Yeah.
pain. So
Okay. Hmm. Okay. So now that we finished the spine, legs, knees, feet. So we probably have the hip, like the pelvic bone, hip.
Oh yeah.
Yeah.
So one very important topic I would like to
Mhm.
touch upon here is developmental hip dysplasia.
Okay.
Although it's a reasonably rare problem,
Mhm.
unfortunately, it is diagnosed quite late also.
Okay.
Hmm? So till the child starts walking and the child starts
Mhm.
walking funny, the
Yeah.
parents never notice that there was a problem.
How would they notice that there's a problem?
See, typically we have something called as screening for developmental dysplasia of the hip.
Okay.
So there is a ultrasound scan which can be done.
Okay.
Typically, as a routine course, it is important
Mhm.
for all kids to undergo that particular scanning, according to me.
Okay.
So what we check is, we check the orientation of the cartilaginous as well as the bony labrum. Again, it becomes a little too technical,
Mhm.
but what the radiologist sees
Okay.
is basically the angulations.
Okay.
Okay, the angle at which the acetabulum is
Mhm.
and the angle at which the femur is
Okay.
sitting. So hip joint consists of the acetabular, which is the cup,
Yeah.
and the femur, which is the bone.
Yes.
Right. So the orientation between the two, if at all it is slightly away
Oh, so it's a
from
very
normal.
simple, like non-invasive test that they can
Yes.
just see.
It's very very easy also, and although you need a specialized
Yeah.
musculoskeletal guy who knows what he's doing,
Yeah.
most people will be trained in this.
Okay, so if they can just do it as routine. So
Correct.
when is the earliest that they can catch it? Like say they're doing the ultrasound, which is the earliest time?
So, see, initially, it takes at least a month for the hip to actually completely form well.
Okay.
Uh, that being said, at the time of birth itself, we can always do a DDH screening. But many a times, what happens is the angles are more than what it is
Going to be?
going to be.
Yeah.
Many a times, we get a lot of false positives. So that is where we tend to probably do a repeat scan in
See,
kids.
but when they're coming for their vaccination, I mean, I think this vaccination time is a great time for
Yeah,
like all
catch hold of
screening
them and
tests.
yeah, do the
Like
screening.
check
That
everything.
is the perfect time
Because
for them
anyway
to
they're
do.
coming. Parents are terrified. They're like, yes, we have to get our vaccinations done on time. So they're coming to the hospital every like month, or every like 3 months, 6 months, 9 months,
I
right?
think 1 month is
So,
the best time to do it, and it's supposed to be more precise
okay.
during the 3 month period.
Okay.
1 to 3 months is
Okay.
when it is
And we
supposed
have
to be more.
vaccinations at that time. So
Correct.
best. Yes. Check it then.
Yeah. So if at all
Mm.
we catch
Yeah.
any of these kids during these screening tests, we can just treat them with a simple harness called Pavlik harness.
Okay.
Okay, it's like a belt which comes from the chest
Okay.
all the way to the knees,
Yeah.
which holds the hips up and out.
Okay. Lovely.
Okay,
Hmm.
and that tends to usually take care of the problem.
Oh, that's
because
amazing.
bones are malleable, joints
Yeah,
are still malleable.
yeah.
As and when the child grows,
Exactly.
they typically come out of this dysplastic
So
hips
how long do they like stay in the
till
strap?
6 months.
That's amazing because that time they can't say no and they can't pull it out. So
Exactly.
the best
So
time.
if for whatever reason the hip is not developing well even with the harness,
Okay.
at 6 months of age we typically do either a closed reduction of the hip
Okay.
and put something called as a spica plaster.
Okay.
And typically as and when the kids grow older, closed reduction sometimes might not work, and that
Okay.
is when we need to open the joint.
Okay.
There will be some sort of restriction to the femur from coming back and sitting in the place.
Okay.
So basically what happens in hip dysplasia is the acetabulum is the cup,
Yeah.
and this is the ball, the femur is the ball, and the ball has to seat well inside the cup.
Yeah.
Correct. So here what happens, because of whatever reason, either the hip is the cup is shallow, or there is some impinging factor.
Okay.
Either way, the hip, the ball doesn't come and sit inside well.
Yeah.
So because of this, if the closed reduction doesn't work, we tend to open the joint.
Okay.
We tend to clear out
Whatever was
is
impinging.
the reduction, and then we tend to open reduce the hip joint.
Okay.
And if for whatever reason over a period of time, as and when the kids grow, if the acetabulum is shallow, we do procedures on the acetabulum.
Okay.
If the femur sometimes if there is any change in the orientation of the femur, we tend to do osteotomies of the femur also.
Okay.
So all these things, again, like I said, each child is different.
Yes.
Individual cases we have
Yeah.
to evaluate well, and then go for
Okay.
procedures. And that is where in terms of pediatric orthopedics especially, it's very important to evaluate the kid well.
Yes, of course.
Because it's not easy to examine a pediatric
Yeah.
child.
Yeah.
They'll be wailing, they'll be crying, they want to get out of the place.
Yeah.
More often than not, before coming to you, they would have visited the pediatrician, would have pricked them with
Yeah.
vaccine. You know,
Yeah.
when they come to see you, they're petrified of you.
Yeah, of course.
And that is where the skill is more in examining the kid rather
Yeah.
than doing the
Of course.
surgeries and having a good plan.
Yeah.
So pediatric orthopedics is 90% planning and 10% execution, according to me.
Yeah. No, of course, like because it's per case, right? Like how is it going to
100%.
affect that child?
Correct.
What needs to be done? What does not need to be done?
Yes. 1 plus 1
kind
is
of
not
things.
always 2 in pediatric orthopedics.
Totally. Could be 3, could be 5, could
Yeah.
be 1937. But yeah, works according to each child and their individual case.
Correct.
Yeah.
And coming to some other hip issues, we have we were discussing about how infection, untreated infections can cause like
So gait problems.
correct. We have something called as coxa vara and coxa valga. That is something. See, the normal orientation of the femur, that is, femur consists of the entire shaft of the femur is one part. There is a neck which articulates with the inside the joint of the hip, right? So the angulation between the two, it is supposed to be anywhere between 120 to 135 degrees.
Okay.
Anything less than 120 degrees, we call it as coxa vara. Anything above 135, we call it as coxa valga.
Okay.
So either of these problems can disrupt the liver arm function of how we walk, and that can cause the kid to walk funny, and that that needs to be addressed.
Okay.
Similarly, there are other adolescent hip issues like Perthes disease. I think recently Kedar had come with the Sever's
Yes.
problem.
Because
Something
growing pains.
correct. Something similar can happen in the hip joint also.
Okay.
Now, why it becomes important, especially in hip joint, is because over a period of time, since it's a weight-bearing joint, it tends to cause fragmentation, and as the fragmentation heals, it tends to heal in a weird way. It doesn't heal with the spherical shape of the ball what is supposed to maintain. That doesn't maintain.
Okay.
And that is where interventions become important.
Okay.
And Perthes typically the kid tends to walk with a little bit of limp.
Okay.
Pain develops later. It's always the limp which comes first.
Okay.
Yeah, that is a very important marker. If the child is walking with a limp but he's able to do all activities, I sincerely request the parents to not neglect that particular problem.
Okay.
This is
so
one
a
thing.
limp is something that's important to
100%,
be evaluated.
100%.
Okay.
And as we are touching on hip, one more topic would be something called as a slipped capital femoral epiphysis.
Okay.
So what happens here is, typically in an overweight child, usually the femoral physis tends to slip.
Okay.
And that causes again the child to walk a little funny.
Okay.
With a lot of pain, especially in acute slips.
Okay.
They present with severe pain.
So in Perthes, there's no pain. Not much.
Not in the
initially.
first initial phase. Over a
Okay.
period of time, they develop pain.
Yeah.
But initial presentation is always limp in Perthes.
Okay.
Whereas in slip capital femoral epiphysis, it's usually severe pain.
Okay.
Typically, when they, it's a very trivial, either a slip while walking down the stairs.
Okay.
One of these things can cause this physeal
Problem.
slip, and once it slips,
Yeah.
it's extremely painful.
Okay.
And again, there we evaluate what is the angle of the slip and whether we can just get away with something called as an in situ fixation,
Okay.
wherein we put a small screw through the physis and just stabilize that particular slip.
Okay.
Typically, when we do it, we also prophylactically do it on the opposite side also. So this
Okay.
is something of a bit of controversy because the problem is on the right hip. Why are you operating on the left side?
Yeah. Of
So,
course.
kid who has slip on one side, they typically have, they're more predisposed to having a slip on the
On
opposite
the other side as well.
So that is the reason why we usually prophylactically do the other surgery
Okay.
also. So that, I think, covers most of our hip problems.
Yeah.
Of course, see, we were discussing about how infection can cause problems.
Yeah.
There is something called as post-septic hip sequel also
Okay.
that can cause varying degrees of damage to the hip joint,
Okay.
and that eventually causes the kid to develop arthritis.
Okay.
So that is where sometimes we tend to do some hip preservation surgeries to, probably postpone the arthritis.
Arthritis as
We
much
were
as
discussing
possible.
about, yeah.
Yeah.
Remember how we were discussing about, when there
Hmm.
is infection, the room is on fire.
Yeah. Yeah. So
So
you need to put out that fire first
now that
before.
the fire is put
Yeah.
out, the second thing is what damage the fire has done.
Yeah.
So that comes
Totally.
later. So
Okay.
that is where your sequels come into picture. So
Yeah.
all the more reason for kids with typically bone and joint
Mhm.
infections.
Mhm.
It's very, very important for the parents to have a regular follow up with our pediatric orthopedicians.
Okay.
Because
Yeah.
uh, it's it can happen at any point, because as the kid grows,
Mhm.
that is when we assess the damage, whether it has been damaged or not.
Okay, so if they have to come and visit you after they've come, right? Like for the sepsis, now how often should they come? Every month, every
Initially,
3
no. For the
months?
first year, we call them at 3 monthly intervals,
Okay.
and post that, we usually call them yearly ones.
Okay. Yeah, just to see how it's progressing.
And
Yeah.
if at all, again, like I said,
Mm-hmm.
everything is individual.
Yes,
So
of
some
course.
kids we tend to call, on an earlier basis.
Mm-hmm.
It really depends on how what we are looking at, and
Mm-hmm.
whether there is anything which we are suspecting. Typically,
Okay.
if we see that something is probably not as well as it's supposed to be,
Mm-hmm.
we tend to call them on regular follow-ups.
Okay.
And many a times we see that because of the infection,
Mm-hmm.
the physis would have gotten damaged, and because of the
Okay.
damaged physis, there will be some other problems which,
Like growth restriction.
similar to how we see your bow legs and your
Mm-hmm.
knock
Yeah.
knees,
Yeah.
coxa vara, coxa valga, anything can happen.
Yeah.
Same thing can happen in your elbows also. Same thing can happen
Mm-hmm.
in your shoulder also.
Mm-hmm.
So all these things, they require some sort of uh, evaluation
Mm-hmm.
and intervention if need be.
Okay.
Yeah.
Nice. Okay. So now the other thing is gait. What do you think parents know about gait? What do they not know about gait? What do they need to know about gait?
See, one very important thing for the
Mhm.
parents to understand
Mhm.
is kids, they are not born with the ability to walk.
Okay.
They learn it,
Uh-huh.
correct?
Mhm.
So as and when the child starts walking, obviously the child will not walk normally like how me and you walk.
Yeah.
So initially when the child starts walking,
Mhm.
they typically walk with a wide stance gait.
Okay.
Both the legs are outwards,
Mhm.
and they have a wide, base of
Yeah.
support,
Mm.
and from there they walk.
Yeah.
Okay. And that slowly, as and when the child grows,
Mhm.
they typically attain that adult like walk pattern
Mhm.
by around 4 to 5 years of age.
Okay.
Okay.
Hmm.
And the most common problem what we see
Mhm.
in terms of gait is something of an equinus gait.
Okay. Mhm.
So typically when we walk
Mhm.
on a flat surface,
Okay.
the heel is the one which strikes first,
Okay.
and then the foot, and then the
Okay.
forefoot, and then we launch.
Yeah.
Correct.
Mhm.
So what happens in an equinus gait
Mhm.
is basically uh, the forefoot strikes first.
Okay, so tiptoeing.
Tiptoeing gait,
Yeah.
exactly. So that tiptoeing gait is the most common problem which the kid presents with.
Okay.
Many a times these tiptoeing gait is
Mhm.
associated with some or the other anomaly in the foot, or in
Okay.
the ankle, or
Mhm.
sometimes in the gastrocnemius itself. That is the
Okay. Muscle.
the calf
Huh.
muscle.
Yeah.
Okay, calf muscle tightness is the most common problem.
Okay. So why do
But
they get calf muscle tightness?
see, most common problem is a spastic
Mhm.
problem,
Which happens.
spasticity. Again, it's either in cerebral palsy or cerebral palsy-like conditions,
Okay.
wherein there is some sort of cerebral insult during childbirth.
So they won't have the other issues, but they'll just have tiptoeing sometimes?
Many a times, yes.
Okay.
So these are these are the kids who do well in life.
Okay.
Once
Okay.
we
Mhm.
go ahead with either a stretch plaster,
Mhm.
Botox injections, or
Yeah.
in an older child, surgery.
So tiptoeing post the age of 4 is a red flag. Parents should come.
See, I think if a child is tiptoeing, it's important that the parents get it evaluated as early as
Evaluated?
possible.
Of course.
Yes, because tiptoeing is not normal at any age.
Okay.
Mm.
Okay.
Because what happens is many a times these kids have something called as idiopathic toe walking. So wherein there is absolutely no other cause what we do from examination,
Okay.
but the child has this
Different.
walking pattern. So these are the kids in whom we usually put something called as stretch plasters, which
Okay.
stretch out the muscle. And once we take the plaster out, we put them on some braces like
Okay.
AFOs and ankle foot orthotic
Yeah.
braces. These things, they typically tend to make the kid better.
Okay.
And once we take it out, they start walking better.
Okay.
So this is a simple stretch plaster. If it is preventing the problem, I don't see why the parent should be hesitant of this particular
Of course.
issue.
Yeah.
Definitely, as and when the age progresses, the deformity becomes more and more rigid.
Okay.
Interventions become more and more morbid.
Yeah, that's true. Okay.
And apart from that, there are other different gait patterns. Typically, if there is a short limb,
Okay, that will be limping.
There'll be a little bit of limping, and that is where up to 2.5 centimeters, the body tends to take care of the problem.
Okay.
If it is beyond that, that is when it tends to show as a short limb gait.
Okay.
Again, there, when it comes to intervention, how we were talking about 8 plates for that angular deformity, like how one side we restrict. Here what we do is, there are two options which we can do.
Okay.
Either we can lengthen the short bone,
Okay.
or we can shorten the long bone.
Okay.
So what we do is, if at all we go in for opt for shortening, we tend to put 8 plates on both sides.
Okay.
Arrest the physis, let the other bone catch up.
Yeah.
And once it catches up, we take away that plates and then they start growing together.
Oh, nice.
So this is one thing. Again, here the surgery happens on the opposite leg.
Yeah, yeah.
So parents are extremely confused. They're like, why are you operating on the opposite side? My kid has a problem on this leg.
Especially since the Genes movie, right?
Exactly.
Yeah.
Exactly.
It's like, okay, they did the operation on the wrong side.
On the wrong side,
Yeah. So, yeah, sometimes it has to be done. Not always, of course.
Not always, of course. Yeah.
But yeah. Yeah.
So, or the other option is wherein, we can do something called as distraction osteogenesis.
Okay.
So, basically what we do is we can lengthen the bone. In fact, you'll not believe, we have lengthened close to around 18 centimeters in a kid.
18 centimeters.
18 centimeters.
That's like longer than the 15 centimeter scale.
Yeah.
Yeah.
So, what we do is, under controlled atmosphere, we tend to gradually distract the bone.
Okay.
So we'll be putting external fixators. It can either be a monoplanar fixator or a ring fixator.
Okay.
We typically distract it by 1 millimeter every day.
Okay.
It is done in 4 intervals, like 0.25 millimeters every 6th RD. Okay. So gradually the bone starts forming.
Okay. Nice.
It's very beautiful. In fact, it's a little complex procedure, but that being said, it's a beautiful procedure to do.
Okay, nice.
So,
now that you're saying that you're making bones grow longer, parents will be like, okay, what can we do to optimize the height of our child? Anything?
You'll not believe, I've had so many requests like that. My child is short when compared to his peers. We want his bones lengthened. Can you do it?
Yeah.
Like, again, nothing
No,
here.
naturally. I'm asking naturally.
Naturally. I mean, there are, if you want us to lengthen cosmetically, I don't think it's a good idea.
Yeah.
That
even
being
I don't
said,
think so.
there are so many people who have underwent this procedure for plain cosmetic reason. And, many of them, they're doing well. But there are complications in these procedures also. We have to understand that, they're not simple things to do.
Yeah.
You'll have to be on a fixator for easily close to around 5 to 6 months,
Yeah, that's difficult.
Very difficult. And because of that, we end up with one or the other stiffness of the joints. We need to do physiotherapy for that.
Yeah.
All these things are
like if it's not required,
it's not
why
required,
do it?
Exactly.
Yeah,
my suggestion is, love yourself. If you're short, big deal.
Because that's also a question, like, that's what they come and ask you, right? They're like, okay, doctor, my child is not growing like everyone else is taller. What to do?
Yeah.
What can we give him?
So
anything else?
On this topic, I would like to touch upon one more thing, basically the height of the kid.
Yes.
Typically, when we take an average of the mother and father's height, typically the child should either be 10 centimeter less or more than that average.
Okay.
Okay, that is the normal thing.
Yeah.
Okay, at any point in time, if the child's height is less than that, that probably should ring some alarm bells.
Okay.
Okay. Typically, again, frank dwarfism is something completely
Different.
you know, different. I mean, it all comes in the same spectrum of problems. We have something like short trunk dwarfism, short
Okay.
limb dwarfism.
Yeah.
Even in short limbs, there are different types. Whether there is a shortening of the proximal segment, the middle segment, or the lower segment.
Okay.
So each of these things, there are different problems associated with it.
Yeah.
Probably the most common one is our the Tyrion Lannister.
Yeah.
He has something called as achondroplasia.
Okay.
So he basically, it's a genetic problem.
Yeah.
Unfortunately, in our situation, in our country, more often than not, dwarfism is a neglected topic, because what happens is they'll be associated with so many other problems. They'll be associated with so many other metabolic as well as structural issues, which needs to be addressed. But
has to be nutritional deficiencies only, no?
No.
Like
This is more of a genetic problem.
Okay, like genetic,
Yeah.
fully.
Yeah. So either there'll be a mutated gene, or it is something which is passed on.
Yeah. No, mainly it's like, but if it's fully genetic, then you can't do anything to change it as well. But say, okay, you already know that like one parent has this in their genes or something. How can you prevent it?
Definitely, we can do a few tests in the amniotic fluid itself.
Yeah, in vitro.
In vitro.
Okay.
And based on that, if at all there is a problem, the parents can take a call whether they want to continue with the pregnancy or not.
Okay.
So
anyway, now they're having DNA manipulation these days, like before the pregnancy only. So might as well check that before it
that
happens.
is one
I
thing
suppose,
probably we can think
in
about
the future.
as and when AI develops in future.
Yeah. No, because that is actually like a problem by itself, and like a whole thing, right? Because their way of life and everything that they have to do.
100%.
So are there any like recent advances in pediatric orthopedic surgery that you're excited about?
See, AI is coming up in everything,
Yeah.
So now we have a few AI based applications which actually tell us the final length of the deformity, final length of if there is a limb-length discrepancy.
Oh,
there
amazing.
are computer based applications which give us a fair bit of an idea, and which is more than 95% accurate. They're really good.
Yeah.
And second thing is, other thing what I'm really excited about, in fact we have done a few procedures also, is computer assisted procedures.
Amazing.
We recently excised an osteoid osteoma.
Like robotic, you're saying?
Computer assisted navigation.
Oh, nice.
So it's a very beautiful radiolucent marker which the computer can detect.
Okay.
And when we have the
so you have to cut less.
It's very, very minimally invasive. Before this, we were worried about the amount of bone we need to remove, especially in tumors and this and that.
Yeah.
So here, we pinpoint that particular location of the tumor, and my navigated assisted device shows me where I go if I go in this direction.
Okay.
In all the 3 dimensions.
Yeah.
So I can just know where I'm going before I reach there.
Yeah.
So it is so easy for me to actually go to the pinpointed location and take away the entire tumor. It becomes easy.
Yeah. Like so much better. Like
Correct.
unnecessary loss is all like minimized.
Yes.
Nice.
And another thing probably would be 3D printing. If we were talking about how the shepherd crook deformity, it becomes so difficult for me to do the surgery. So what we do is we take a 3D printed model of it, do the surgery on the model first, see what happens when we correct it, whether we are achieving a full correction. This again, there are a few applications which do it on computer also, but personally I would like to have a 3D printed model with me, so that
because you can feel
I can see, I can feel, I know where I'm cutting, what I'm doing, and how much I'm supposed to do.
Yeah, absolutely.
So, it's brilliant. I'm really excited about that particular aspect.
Nice,
in fact,
nice.
we have done a few surgeries with these 3D printed models, and it makes my job so much easier.
Yeah, because then you don't go into that stress because you've already done it.
Correct.
So now you're just going to go do it again.
One
Same
practice,
thing.
the second one it becomes easier.
Absolutely. Very nice.
So, yeah.
Yeah.
I mean, let's see how things go.
Yeah.
Like how we have these robotic TKRs now, knee replacements. Probably
Yeah, yeah.
we'll end up having something with the robotic hip preservation or something.
Yeah,
I don't
yeah,
know. We'll
yeah,
see how
yeah.
things go.
And like maybe even for clubfoot without putting the plaster and like making them wait for a
I
very
mean,
long time.
probably a long shot, but yeah,
Yeah,
why not?
yeah. Like maybe a more assisted way.
Yes,
Yeah.
probably yes.
Because like
Probably yes.
assistance makes life so much easier.
100%. 100%.
Yeah.
Yeah.
That'd be amazing. Okay, so thank you so much, Dr.
Thank you so much
Manjush,
for having
for
me.
being with us here today. And hopefully, we have clarified any doubt that any parent has on any kind of pediatric orthopedic deformity. When you have to go to the hospital, when is it okay? When should you get the evaluation done, and how that helps you in your future, like, like planning and all of that. Really hope this helped you.